Hello. Yes. Uh-huh. Uh-huh. There's a meeting till 5:30. After that, you can meet me. And you come. No, 5:30 is 5:30 is the online meeting. After 5:30, I'll talk to you. Okay, the 5. Wait. Okay. Okay.
Sir, it's sharp 5. With all your due permission, can we begin?
Yes.
Good evening, everyone. This is Batul, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. Sir needs no introduction, but it is my honor to introduce him at our platform. A very renowned nephrologist, Dr. Ratan Jha, sir. Sir is MD, DM, DNB, DTCD gold medalist, FISN, senior nephrologist and transplant physician at Care Hospitals, Outpatient Center, Banjara Hills, Hyderabad. With the help of sir, we'll be taking a close look on today's topic, which is nephrolithiasis, an overview as a nephrologist. Let us move to the topic and let us know more about it, what the topic says. Kidney stones are hard deposits consisting of minerals and salts that develop inside the kidneys. They are also known as renal calculi, nephrolithiasis, or urolithiasis. Kidney stones can be caused by a variety of factors, including diet, excess body weight, various medical conditions, specific supplements, and drugs. We'll be knowing more about the topic with the help of Sir and with his interactive session. Now, without any further delay, I would like to welcome Sir at our platform and would like to hand over the session to him for his talk to begin. Sir, over to you. Please proceed.
Good evening, everyone. Today, I am going to talk to you about nephrolithiasis, an overview as a nephrologist. You will all agree that the kidney stones are basically treated more often by urologists than a nephrologist. But patients many times prefer to come to a nephrologist to at least look at whether they can get managed with a medical treatment rather than to go for surgical intervention, which they want to avoid and they're worried about it. So as a nephrologist, we treat the kidney stones as often as the urologist, and we are trying to present our ways of dealing with this situation when we see the patient in our day-to-day follow-up. The key concept as a nephrologist that we try to tell the patient is that kidney stone is not a disease in itself, but it is a manifestation of the underlying risk factors and the lifestyle issues that make it happen. The concept is much like anemia, which is not a disease in itself, but rather a manifestation of a disease that causes anemia. So kidney stone is not a one kind of issue. It is related to many things, which ultimately produces or makes it happen in the kidney or the lower urinary tract. So the agenda of my this discussion is going through the following heads for the simplicity sake, that we'll introduce that point why as a nephrologist we need to be aware of this common entity. How do they present to a nephrologist rather than to a urologist? What are the stone composition and the pathophysiology, which is the basis of suggesting the therapies in a scientific way? What are the acute treatments? What are the chronic treatments for its prevention? What is the term medical expulsive therapy? And we conclude as a nephrologist how we try to take care of patient in a simple way. The kidney stone is a kind of a problem which is increasing in its prevalence, and it is now reported that 1 out of 10 patients, 10 persons will develop stone in their lifetime. That is the prevalence, lifetime prevalence of stone is increasing from the earlier 5% to 10%. And it recurs. The recurrence is close to 50%. So reports have varied from 50 to 70% depending on the reports. So stone which happens has to be followed up with preventive measures to prevent its lifetime recurrence. The factors which have led to increased risk of stone in the recent time is the changing dietary habits. That is, we are consuming more and more fast food which contain a lot of salt. The global warming, which is a kind of risk factor, which is increasing the risk of stone. The ever-increasing obesity, because it is now talked that by my next 2 decades, 50% of population in the world will be obese. So this is a new risk factor which has emerged. And then new dietary fads that many times we try to use fruit and fruit drinks, which are citrus fruit drinks or vitamin C therapy, thinking that this is a kind of approach which can have a kind of good impact on the health. So these are the changing factors which has increased the lifetime risk from 5 to 10%. And the systemic disease, if you look at it, diabetes is considered to be one of the very major kind of systemic risk factor besides the bariatric surgery. So a common disease, increasing prevalence, increasing risk of recurrence, and hence the nephrologists are interested to understand how to treat this problem and prevent its recurrence. This is a very simple slide to show that how the stone ultimately develops or forms. So whatever food that we are eating, the ions in the food ultimately passes in the urine as crystals. The crystals ultimately can get deposited at a specific site to produce a kind of nucleus over which more and more crystals can get deposited to grow. And the growth of these crystals ultimately leads to a kind of big stone formation. So the crystals to stone is either promoted by certain factors or demoted or inhibited by certain factors. And that is the way a kind of solution in the form of urine is passed. That if this urine becomes supersaturated with crystals, it produces stone. And if it is present, if it is not supersaturated, or even if it is supersaturation, if the inhibitors are there, the stone is not formed. So the crystals ultimately go to the phase of nucleation, then epitaxial growth, that is on the nucleus, the more and more crystals get formed. And when the crystals become bigger in size and they solidify, they produce a kind of stone, which is called calculus in the medical terminology. So the crystals have been identified in different kind of histological and histopathological specimens as Randall's plaque, which was considered to be the basis or the base where the more crystals are formed. And earlier it was reported that the tip of the papilla are the sites where first of all the nucleus or a crystal gets deposited, and over which the ultimate crystal keeps on building up to produce stone. But the recent reports suggest that these kind of plaques are happening at the level of thin descending limb of loop of Henle, from where the crystal becomes bigger in size and ultimately it erodes the pelvic calyceal system to come into the drainage system to produce the stone symptoms. So the site may be different, but the concepts are same, that the crystal gets deposited to become bigger in size to produce stone. So this concept of stone formation is shown in this simple diagram, that if in a glass of water, 1 spoon of salt is added, 2 things can happen. If you are studying the water with added salt, it may totally dissolve, and it can look totally transparent as is seen on the right side. Or if you are not studying, or if there is any kind of stasis of the water that happens in an obstructive kidney system, the salt which should have dissolved will not get dissolved and it will get precipitated, and it may be the nidus or the kind of site where more and more kind of crystals can get deposited to produce stone. So what is shown in this picture is that if there's a flow, which can be which is the usual thing in the case of drainage system, the small amount of salts which are coming in the urine can get dissolved and can pass in the urine. But if the flow is obstructed, the same thing can get deposited to produce the stone rays. The second situation is shown in the slide, that if we add too much of salt. Even if you are stirring it, the salt may not get dissolved, and the salt can get deposited in the glass, like it happens in the kidney, to become big in size, which is called stone. But this deposition can be inhibited by certain things, like the negative, which are said to influence the pH of the solution. Like lemonade, if you are taking some amount of salt and you mix it, it gets dissolved. There's not much of precipitation of salt. So this inhibits the kind of salt precipitation because of change in pH and many other factors which prevents crystallization. Same concept is used when using alkalizer or a kind of fruit juice for preventing the stone risk. So adding a kind of inhibitor for precipitation of salt could be a kind of concept which is utilized to prevent stone formation. So this solute in solvent, if solute is in excess or solvent is reduced or inhibitor is not there, there is a risk of stone formation, and which is usually targeted in our day-to-day practice. So the stone ultimately forms in a simple way when you have low urine volume, like in a hot climate or because of global warming, in the high risk profession where persons are sweating in the sunlight for any other kind of work, like marathon runners or those who are working in the field with hot humidity. High concentration of solutes, which ultimately is measured as hypercalciuria, hyperoxaluria, hyperuricosuriasia, cystinuria in urine. If it is coming from diet or because of some pathological process that can produce stone formation. Persistently abnormal urine pH in the form of alkaline urine, as is seen in case of renal tubular acidosis, it produces the risk of calcium phosphate stone. And persistent bacteriuria tract infection produces steroid stone. So the pH is also important to keep the thing in solution. And if the pH is alkaline, that is more than 6, the risk of stone increases so for calcium phosphate as steroid stone is concerned. Persistently acidic urine, that is when the pH is close to 5, the uric acid stone risk increases, but in people who are having metabolic syndrome, gout, or who are taking a lot of non-nutrient food, which would make the urine acidic. Low amount of crystallizing inhibitors, which could be a kind of defect in the kidney, that is hypocytasuria or hypomagnesuria. That is, if it is, these are the things, citrate as well as magnesium is said to inhibit the stone formation, and if they are lesser in urine, the solute solvent may not match with each other, and there could be precipitation of salt, and that produces stone. So these are the regions which are shown in a very simplistic way to say why the stone can form and what are the options that we can use to prevent the stone formation. So pathophysiology of nephrolithiasis is that when there is supersaturation with more solute or less solvent or reduced inhibitor, the crystal will aggregate. So any combination could be there to produce stone formation. The supersaturation could be intermittent. That is when person is sweating at a particular time, the intermittent supersaturation happens where when you develop a kind of precipitation of crystals at specific sites like Rander's plaque, which ultimately can keep on increasing in size with the deposition of other crystals at different times. So intermittent supersaturation is as important as continuous supersaturation. When there is a defect in renal transport of calcium for some reason, the hypercalciuria, or anatomical defect in the kidney in the drainage system, when the flow is affected because of the PUJ junction abnormality, that is the pelvic junction the constriction, or in the case of medullary sponge kidney or polycystic kidney disease, the risk of stone increases. It is said that even the urine tract infection which changes the urine pH increases the risk of stone formation because of the kinetics that pH ultimately makes the calcium, phosphorus, as well as magnesium and ammonium salts precipitate in the system. So these are the pathophysiological concepts of nephrolithiasis which has to be addressed in the clinical setting. So the constituents of renal stones are seen that the stones can have varying shapes and size, and they are usually made up of calcium, oxalate, phosphate, uric acid, occasionally cysteine, and the magnesium ammonium phosphate, which is a kind of steroid stone or triple phosphate stone, which is usually associated with the infection and usually is having a staghorn kind of configuration in the kidney, which is detrimental for kidney's health, and kidney failure can happen in case it is not taken care of. So this is just a kind of pictorial kind of the description that if you are trying to see the urine its crystals, the calcium oxalate crystals could be dumbbell shaped or envelope shaped, and these are either because of monohydrate forms of calcium oxalate crystal or a dihydrate form of calcium oxalate crystal, which is envelope shaped. But these crystals are not by itself diagnostic of any kind of kidney stone. They may present even in the normal situation. The calcium phosphate stones are shown. It is just like a prism-like crystal. So we can make a kind of assessment that is there increased amount of hypercalciuria with stone risk. Stewart stone is said to have a very typical kind of image, that is, it is coffin-shaped crystals, and in the appropriate setting can suggest that is the stone that we see on evaluation radiologically or by in the context of kidney disease stone evaluation is a Stewart stone. Uric study crystals are usually football shaped or rhomboidal crystal, which is a bit yellowish in color, and only crystal which gives a diagnosis of the etiology is cystine crystal, which is hexagonal in shape. This is one of the least common type of stone in our day-to-day practice. So the urinary examination, where we get reports of presence of calcium oxalate crystals or uric acid crystal, is not diagnostic of anything or not suggesting that the person has a risk of stone by itself. So the reason why you get this calcium oxalate stone could be because of the associated condition like hypercalciuria, hyperoxaluria, when you get more kinds of calcium oxalate stone, or the calcium phosphate stone can come as shown in the slide with the diseases which are associated with increased amount of oxalic acid production. Calcium phosphate stones are usually seen with disorders where you have renal tubular acidosis. Stewart stone is usually seen in UTI condition. Uric stone is seen in situations where there is a kind of metabolic syndrome, and cystine is a congenital disorder where you have many other kinds of things which may be there in the urine. So if you look at the prevalence of different stones in nephrological setting, most of the stones are calcium oxalate stone. And the commonest crystal that we see in the urine is also calcium oxalate. That doesn't mean that is because of this we are saying that person is having calcium oxalate stone. The normal amount of, normally what we see in the urine is the calcium which is getting excreted along with oxalate, which is also getting excreted which is coming from the gut or from the metabolic process. So that is a normal constituent of urine, but it can get precipitated if the calcium is high or oxalic acid is high, or both are high along with absence of inhibitors. So calcium oxalate stone is the commonest stone that we see, which is a radio opaque stone. The second category of stone that one sees commonly is the uric acid stone, which is usually radiolucent, but it could be become the nidus over which the calcium oxalate can get precipitated, and we may get a kind of mixed type of radiological opacity. Stewart stone is again another common type of stone, and calcium this phosphate stone is the second commonest category of stone which is containing calcium, which is radio opaque, but not as hard as calcium oxalate stone, because we need to understand the calcium oxalate stone are very hard, and extracorporeal shock-wave lithotripsy may not be able to break the stone. So we need to have some idea about the stone composition, because it may have a bearing in decision of treating stone with which kind of modality. The calcium oxalate stone, which is the commonest stone, is formed from the crystals of calcium as well as oxalate, and it is the most commonly recognized stone throughout the world. There is no exception that this in any part of the world this is not the commonest stone. Oxalate is considered to be an unusable end product of mammalian metabolism, and the urinary oxalate is derived from both the indigenous source that is coming from the metabolism of proteins primarily produced by the liver, and it is also coming to some extent from the diet. Almost 80 to 90% of kidney stone forming individuals form calcium oxalate stone, and either there is a hypercalciuria or hyperoxaluria or both, which are risk factors for this kind of kidney stone in such patients. The common metabolic abnormality that we see in a kidney stone is therefore the presence of either hypercalciuria, which could be of different types, absorptive hypercalciuria, resorptive hypercalciuria, hypercalciuria associated with primary hyperthyroidism or renal hypercalciuria. The other metabolic abnormality could be hyperoxaluria, that is a lot of oxalates are there in the urine, hyperuricosuria, hypocitraturia, that is less amount of citrate, which is a commonly inhibitor of stone formation. And this abnormality in the urine could be associated in the blood with hypercalcemia, hyperuricemia, or a renal tubular acidosis. So these are the metabolic abnormalities that one needs to evaluate in a person who develops repeated stone or who are having a kind of bilateral stone disease. The reference values for these abnormalities are shown in the slide, that any person who has a calcium species more than 300 if male or more than 250 female in 24 hours is hypercalciuric. Oxalate in the urine in milligram should not exceed more than 50 milligram, and if it is more than that, this person is having a hyperoxaluria, which is same for both males and females. Uric acid excretion in 24 hours should be less than 800 for males and less than 750 for female. And if it is high, it is called hyperuricosuria. Citrate, which is a normal kind of inhibitor for stone formation, should at least be more than 325 milligram in 24 hours. And if this is less, as in cases of renal tubular acidosis, this can produce the risk of stone. pH is very important. Any extreme pH change can predispose to one the other form of stone. The normal pH in the urine is 5.8 to 6.2, and it should become 5.3 and below in a person who is fasting. That is the normal where the kidney produces acidic urine. Urine volume is also looked at, and any person who passes less than 1 liter of urine in 24 hours is at a risk of stone formation. And normal good volume of urine is 2.5 to 4 liters, depending on the situation of climate. One should have that kind of stone urine volume. Sodium in the urine should not exceed more than 100 millimole in a normal healthy person who is taking a lesser amount of salt. Any person who takes more sodium has also at increased risk of increased calcium in the urine, which increases the risk of stone formation. So these are the reference values, and these are things which are looked at in a person when you are looking at the metabolic workup of stone disease. So when we talk about metabolic workup of stone disease, we mean what is the risk profile based on the urine examination. This, when evaluating the patient with nephrolithiasis and when trying to interpret the urine risk profile, the following 3 questions we try to understand from the report. Is there any increased concentration present of the lithogenic substance due to higher rates of excretion, low urine flow, or both? Is there any stone promoter present, such as hyperuricosuria? Is there reduced inhibitor present in the urine, particularly low citrate concentration? So these are the things which we automatically comes in the report when the urine risk profile is looked at. So such kind of evaluation of metabolic, which is called metabolic evaluation, is done in a select situation. A person who has developed stone for the first time is called with a low risk recurrence, that we will talk about how to quantify low risk versus high risk. The first time stone formation, we work up with the complete medical history of particularly the family history, the risk factors, what are the medicines is he taking which can predispose to stone formation or not, stone analysis if available, and the urine analysis, particularly to look at the pH, the urine sediment, and dipstick. But the person who develops repeated stones or bilateral stones with a risk factor of high risk recurrence, even if the first time person has developed stone, then beside the usual thing that we talked about, we look at the serum panel for kidney function, creatinine, sodium, potassium chloride, look at electrolytes, calcium, phosphorus, and magnesium, uric acid, and the venous blood gas analysis to look at the acidosis presence or absent. If person's calcium is elevated, then parathyroid hormone and vitamin D is also looked at. 24 hours urine is collected, at least 2 samples apart, to look at the usual volume, pH, sodium, calcium, oxalic acid, uric acid, and citrate. So this is one of the patient's report where we did the 24 hours urine collection. And what was reported in this report was that the person was passing a urine of 1800 ml. So it was reasonable, but lesser for a person who has stone disease. And he was found to have urine acid concentration, citrate concentration, and sodium in the high risk zone. That is, citrate level was low, and sodium that he was consuming was high. Urine magnesium was in the borderline high zone. urine total volume and urine pH was reported to be corrected. All other parameters, including supersaturation index, was within normal limits. So that is how the reports are given. That is what is the uric acid level. Like this patient uric acid was normal. Urine calcium was 167. So this being a male patient, this is also not having hypercalciuria. But he was taking lesser amount of water. He was taking more sodium. Those are the risk factors, and he was having a magnesium which was on the lower side in the urine, and this patient had a citrate level also in the lower side, etc. So these are things which can be corrected by appropriate drug therapy. So the recurrence of kidney stone has a nomogram has been developed. That is the ROKS nomogram, which is shown the recurrence of kidney stone nomogram, where 13 factors are put into the graph to look at what is the kind of quantification of this probability of stone formation. And if based on the graph, we try to say that what is the risk at 2 years, 5 years, and 10 years. Any person who has the risk of stone more than 10% will require kind of workup that we talked about, the urine risk profile. The renal stone, the standard procedure for treating renal stone is to treat the symptomatic renal stone with either shock wave lithotripsy or flexible ureteroscopy, that which is called URS in every term, and in select cases with anatomical malformation, open surgery, which is to be done when we find that the stone is not amenable to a medical expulsive therapy. That is, the stone size is big enough and it may not be able to take care of that. So the standard treatment for symptomatic stone, which is not amenable to this medically expulsive therapy, is some form of intervention in the form of shockwave lithotripsy, URS, or open surgery in case it is not possible. The term medical expulsive therapy, or abbreviated as MET, is shown in the slide. That is the treatment with combination of drugs to facilitate stone passage from, particularly from the lower ureter, is called medically expulsive therapy. Spontaneous expulsion is seen when the stone is below 5 millimeters in size. 90% of the stone can get passed. If it is between 5 to 10, the chances of its passage is 15%. But when it is above 10, the chances of it spontaneously getting expelled or by the drug therapy is practically nil. When we are trying to give this form of therapy, at least 4 weeks we have to wait to see the benefit of this therapy and to see that whether the drug has worked or not. So for 4 weeks, the medical expulsive therapy can be tried in an appropriate patient. And this therapy with the drug therapy was found to decrease the time to pass stone in the lower ureter. So we need to follow up our medical expulsive therapy at 4 weeks with ultrasound examination to see that the things have gone out. In acute situation, the medical expulsive therapy has to be combined with the symptomatic therapy, and the commonest drug that we give for pain relief is diclofenac sodium intravenous, which is very quick acting, though it can be given intramuscular also. Narcotic drugs like tramadol, like in people who may not be the right candidate to get diclofenac because of kidney disease, dysfunction, etc., is also an option that can be tried, or even the fentanyl patch can be used in people who are vomiting. This form of therapy of narcotic therapy is faster, and a similar pain relief is seen after half an hour in both the non-steroidal anti-inflammatory drug or narcotic drug therapy. Antispasmodics are commonly given because person has that kind of colic. Dotaverine, hyoscine, IV or IM can be given. Antiemetics have to be combined many times with pain because pain causes reflex vomiting. And ondansetron is the commonest drug that is given IV along with pantoprazole when we are giving NSAID. Other drugs which has to be given, which will be given after the pain relief, is alpha-1 blocker. Calcium channel blockers and steroid as a kind of cocktail is used for for facilitating the stone passage in a fixed drug combination. Ureteric stone or ureteric which produces ureteric colic is many times a medical emergency, and treatment depends not only on the stone side but at the site where it is located based on the evaluation and the degree of renal dysfunction. Spontaneous expulsion is possible in almost 20 to 30% of patients who are having stone in the ureter. And this medical expulsive therapy has to be tried in this situation when a person is passing a small stone, that also produces severe pain, and one has to give this drug that we talked about, diclofenac sodium or ibuprofen, acetaminophen, or naproxen, depending on the severity, oral or IV therapy, or narcotic analgesic. This is always combined with an anti-nausea medicine because that is the severity judge of the stone producing pain. The suitable candidate for medical expulsive therapy is shown in the slide, that who is on treatment should get this therapy of alpha blocker medication for 4 to 6 weeks. Alpha blocker relaxes the muscle in the ureter to make it easy for the stone to pass. Drinking of plenty of fluids. By the term plenty, I mean 6 to 8 glasses of water, that is 2.5 to 3 liters of water every day, which helps to flush the urinary system if the kidney function is good, to make the stone pass. So this is the thing which is continued for roughly 4 to 6 weeks. And then one needs to evaluate whether the treatment is successful or not. But this form of therapy, the medical expulsive therapy, should not be attempted if the person is having severe pain, recurrent disability, which is recurrent, which usually happens in the night time when the urine gets concentrated. But a person who has significant and persistent urinary obstruction that is shown on the ultrasound or by the CT scan, signs of infection in the form of fever or chills, electrolyte abnormality in the form of hypokalemia or hypokalemia or renal insufficiency. A person who has a single kidney with stone and hydronephrosis may not be the right candidate to be offered this form of therapy. So we have to select the patient that who should be given this medical expulsive therapy. The current trends in medical expulsive therapy, as reported in literature in the American Heart Association or European Association of Urology, the AUA and EUA, the clinical guidelines support the use of this form of therapy for any person who has stone less than 10 millimeter. And this 10 millimeter size is very important because many times the reports gives a conflicting kind of size. Anything less than 10 millimeter, which is best evaluated by CT scan, should a patient should get this form of therapy. In comparison with the surgical intervention for uterine stone, MET has a high safety profile and low cost. And that's why it is recommended both by the American Urological Association as well as European Urological Association. Despite these guidelines suggesting this therapy as a reasonable treatment in patients who are medically stable with symptom control and with a ureteral stone less than 10 millimeter size, somehow MET continues to be underutilized throughout the world, and people go for the definitive therapy in the form of either ureteroscopy or laser lithotripsy. When we talk about medical expulsive therapy, it is not only alpha-1 blocker like tamsulosin, with the commonest drug which is used. Even alpha-dosine in the dose of 10 milligram or pseudodosine in 8 milligram have been tried and found to be equally or more efficacious. Calcium channel blocker could be combined in appropriate patient who in the form of a long-acting drug like Nicardia XL, which is slow kind of release drugs, which will not produce hypotension by itself. IV fluid should be always combined, which is part of medical expulsive therapy along with diuretics. And it is said that 2 liters over 2 hours will be the fluid therapy with diuretics to help the stone to pass out. Deflazacort as a steroid, 30 milligram, or prednisolone 10 milligram in combination with calcium channel blocker are available in the market, which can be used in, for treating such patients who is not getting relieved in a day or two. Phosphodiesterase inhibitor, particularly the tadalafil 5 milligram, has been found to be more useful in combination with the other drugs that we talked about, the calcium channel blockers, steroids, and alpha-1 blockers. The terpenes are a drug which is reported in literature, Novartis 3 times 2 capsule, or the drugs which are used in the Ayurvedic circle as needle stone could be tried. Inversion therapy, where using the inversion table for calcium stone to get disimpacted and come in the urine, is also been reported as part of medical expulsive therapy. The drugs which are used for treating preventing nephrolithiasis is shown in the slide. There are many drugs. One of the common drugs that is to be used to prevent hypercalcemic stone is hydrochlorothiazide and chlorthalidone. One has to note what is the dose recommended to take care of hypercalciuria. The hydrochlorothiazide, the dose is 25 milligram 2 times a day, or chlorthalidone 25 milligram per day. The dose that is usually used in hypertension is much lesser dose compared to the dose that is mentioned for preventing hypercalciuria. So whenever you are using this dose, we need to prevent the other side effects like hypokalemia in a patient who is getting this drug. Potassium citrate, the dose is 20 to 80 milligrams in 3 to 4 doses, but this is a drug which reduces the risk of stone crystallization. Allopurinol, the dose particularly 100-300 milligrams can be used in those who are having hyperuricemia with the risk of increased risk of calcium stone. The drugs like other drugs like penicillamine, thiopurine, these are the drugs which have been used occasionally but we have no experience using these drugs. It is mentioned for cystine stone, the thiopurine or penicillamine. Acetohydroxamic acid is mentioned as a drug which can be used for steroid stone, but it is not available. Coming to one of the very important concepts, the Oxalobacter species. We know that in our gut, Oxalobacter formigenes is there, which contains a bunch of oxalate degrading enzymes like oxalate oxidase, oxalate decarboxylase, oxalate carboxylase, and formyl CoA transferase. These are 3 or 4 types of enzymes which degrade the oxalate in the gut and to produce formic acid and carbon dioxide. Studies have demonstrated that when we use antibiotics for some reason, this kills these kind of oxalate producing bacteria. And with this loss, the dietary indigenous oxalate turns out to be more bioavailable for getting absorbed, and that produces the risk of hyperoxaluria and stone formation. So when we're trying to talk about chronic therapy to prevent stone formation after taking care of stone in the beginning, the therapies which are said to be chemodissolution therapy, the potassium citrate therapy, hyperuricemia, uricosuric therapy, that is for persons who are having increased uric acid, hypercalciuric treatment with the drugs that we talked about, the hydrochlorothiazide, chlorothiazide, right dose, the good dose. Hyperoxaluria treatment can be attempted by giving oxalobacter fumigates as a supplementation in the oral capsule, the probiotics. Other forms of therapies are required for cystine formation, that is, the drugs are there, or steroid stone formation, but they are not very safe drug, particularly steroid stone formation. SGLT2 inhibitors have been found to reduce the uric acid level as well as increase the urine flow. And many patients who are diabetic, this could be an add-on therapy for all kinds of metabolic derangement. Ayurvedic treatment can be also attempted or given for a long time as needy and stone, because that may have some benefit which are difficult to prove. But one of the commonest therapy that has to be remembered and not forgotten is to give fluids, which should be at least 3 to 4 liters a grain. Low sodium diet, which should be contain less than 2 grams of sodium or 5 grams of salt. Adequate calcium, that is 1 gram of calcium should be there in the diet, because low calcium food produces the risk of stone formation. And diet should be appropriate for oxalate and uric acid if the person has having hyperoxaluria or hyperuricosuriia. So in summary, the preventive approaches are using potassium citrate, say 10 ml 4 times a day to keep the pH above 6. Be useful in most of the stone except for the uric acid stone. Magnesium supplementation as oral or in the form of this liquid therapy, which is available with acid, that is which is available in various forms, which is found to have any kind of preventive role. Pyridoxine supplements have been found to be useful in the case of oxaluria. Allopurinol or febuxostat can be used to reduce the risk of uric acid stone. Hygides are usually given for hypercalciuria. Oxalo capsule, which contains oxalobacter, can be used to take care of reduce the risk of absorption of oxalate from the gut. Fluids 3 to 4 liters, low sodium, adequate calcium, and diet appropriate. So preventive spread we talked about. Expulsive therapies are in the form of alpha-1 receptor blocker, like tamsulosin, ampicillin, silodosin, which should be given for at least 1 month. And PD inhibitor like tadalafil has been also used in combination alpha-1 blocker because they facilitate the stone expulsion much better. Calcium channel blockers, particularly in the dose of 30 milligram a day, has been recommended. Deflazacort, if to be given in the dose of 30 milligram daily, if for 7 days, if there is no infection. And SGLT2 inhibitor can be combined, which may have a kind of a benefit for not only diabetes but for uric acid and expulsion of stone. So that was all that I wanted to share with you all about the nephrolithiasis as a nephrologist. And we practice this information in our day-to-day practice. Thank you.
Thank you so much, sir, for your comprehensive talk and such wonderful insight that you have shared upon the topic. We have received few questions and I would like to put it across to you. The first question is, what are the phases of acute renal colic in nephrolithiasis?
Many times we find stones incidentally in the abdomen and there is no acute symptom. The symptoms are many times misleading. Symptoms are only seen when a person is having a kind of stone which is getting out of the kidney and going into the ureter, then only the symptom comes. So a stone which is moving from the kidney down to the ureter produces pain. And when the stone is at the level of the lowest part of the ureter, it produces a pain which gets referred to the tip of the glans penis. That is, pain is so painful. So the stone moving down the drainage pipe produces more pain. Stone which is small in size produces more pain compared to the bigger stone. So symptoms are not always there, and that's why many times we find the tag-on calculus on evaluation of a vague symptom of abdominal pain. So there's no stage as such, but there could be a asymptomatic phase and a symptomatic phase when the person is having a stone moving from the upper urinary tract to the lower urinary tract.
Thank you so much, sir, for answering this question. We'll move to the next question. And the question is, what is the stone score and how is used in the diagnosis of nephrolithiasis?
The stone risk factors are mentioned, but there's nothing that we try to count to say that like this many stones requires to be operated, or this many stones requires kind of non-med therapy, that is medical expulsive therapy. The higher is the number of stone, chances are that it will require an intervention other than the medical expulsive therapy, which is given in every patient as such. So stone number, the more is the stone, more is the risk of treatment failure with medical therapy.
Thank you so much, sir, for answering this question. We'll move to the next question. And the question is, what is the role of complete blood count in the diagnosis of nephrolithiasis?
The complete blood count is usually checked in all the patients who come with acute kind of pain, that is which is called ureteric colic or renal colic, to see whether the counts are too high, which will support a possibility of associated urinary tract infection. But one has to realize that if the counts are high, that by itself is not equal to infection, because any kind of acute situation, there's a body response which is called acute phase reaction, where you have a high WBC count. So if the WBC count is high, the person has fever, or a person has risk factor like diabetes, where fever may not be that apparent, or a patient of other immunosuppressed state where person is getting steroid or some other drug. This can help us to decide to add an antibiotic therapy till we get the report of urine culture, or when you look at the urine examination, we find a lot of pus cells of pyuria. We have to correlate. So if WBC count is high, that shows only the acuteness of process. The person is sick. Person has to be treated with a painkiller, with or without antibiotic, depending on the clinical kind of judgment that is there. So the rise of the WBC count is suggesting that the person is having severe pain.
Thank you, sir, for answering this question. We'll move to the next question and the last question for today's session. And the question is, how frequently is nephrolithiasis misdiagnosed as abdominal aortic aneurysm?
In the recent times, the renal stone is not misdiagnosed unless we are not doing any investigation, because the stones are quite common and easily picked up by the ultrasound examination. The commonest test that we do to pick up the stone and which is recommended is non-contrast CT scan of the abdomen, which picks up the stone 100%. The sensitivity is 100%. So if one has to make a diagnosis of stone disease in a convincing manner, the non-contrast CT of the abdomen, which is called CT-KUV, is done, and there will be no question of making a false or wrong diagnosis of aortic aneurysm. Because aortic aneurysm is a different kind of disease. It's a very uncommon disease compared to the renal stone, which is quite common, etc. That is almost 10% prevalence is there, risk is there in most of the adult patients throughout their life. So this is one is a common disease, other is uncommon disease. Stone is a painful condition. Aortic aneurysm is also rupture aortic aneurysm is a painful condition, but there is no kind of confusion between these two diagnoses. We never diagnose a patient of aortic aneurysm in any patient where stone was found. Many times stones are found incidentally for evaluating something else, and that is not the cause of pain abdomen. So one has to understand that finding a stone doesn't mean that all the symptoms in the abdomen is because of stone, and finding no pain doesn't mean that person doesn't require any treatment, because a neglected stone can lead to loss of kidney function, and the risk of infection could be there, which will lead to a lot of coma, a lot of kind of hospitalization in the future. So we should try to treat stone appropriately, try to prevent stone, because treating stone one time is not sufficient. It's a lifelong kind of taking care of the disciplined kind of food, fluid intake, and preventing the risk factor. So this is a lifelong kind of commitment for a person who has developed stone to remain free of stone. That is, they have to continue taking good amount of fluid, less amount of salt, less amount of non-vegetarian food, and a few drugs which are known to prevent the stone formation, like we talked about potassium citrate, which is simple kind of oral solution which can be continued indefinitely.
Thank you so much, sir, for answering this question. That is the last question for today's session. And at the outset, I would also like to thank you and all the viewers who were continuously stay tuned with us throughout the session. I would also thank you, sir, for taking out your valuable time and for being here at our platform and sharing such wonderful insights, sir. Thank you so much. With all your last comments, sir, we can conclude the session here for today.
Thank you, sir. Thank you for giving the opportunity. Thank you.
Thank you, sir. Good evening.
Thank you.
Bye.